know, I was saying, I keep forgetting lunch and not saying.
Thank you for joining us today for the Psychiatry Grand Round program on July 26, 2017. This program is provided by the Michigan Center for Rural Health in cooperation with the MSU Psychiatry Department, the MSU College of Human Medicine, and the MSU College of Nursing. I am Emma Smythe with the Michigan Center for Rural Health, filling in for Victoria Lancy today. Just a few housekeeping items I'd like to discuss before we begin. Please remember to keep your mic muted until the question and answer component at the end of the presentation. Please remember to mute your mic after you ask your question so that the signal is still clear and other sites are not listening to your conversations. Handouts are located on the MCRH website at mcrh.msu.edu under the Education tab. Continuing education is available today for physicians, nurses, and social workers. Each healthcare discipline has their own attendance or sign-in form, and everyone fills out the same evaluation by clicking on the link and completing it in SurveyMonkey, which you can find all these links on the MCRH website as well. Physicians, please note that there is a new process you must follow in order to obtain your certificate. Directions and the links are located on our website under the title of the Grand Round tab. If you have any questions, please contact myself or Victoria Lancy. Victoria's email is Victoria, VICTORIA .Lancy, LANTZY @hc.msu.edu. The attendance or sign-in forms need to be emailed, faxed, or mailed to the Michigan Center for Rural Health office. The evaluation must be completed online. Please note that we are no longer accepting paper copies of the evaluation. Physicians, make sure your site proctor is signing the sign-in sheets. You will have 2 weeks or by August 9th to complete all these forms. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts as well. There is no commercial support for this program. I am pleased to introduce our speaker for today, Dr. Jeanette Scheid, who will be speaking on PTSD.
All right. Well, good afternoon, everybody. My name is Dr. Jeanette Scheid. I'm an associate professor in the Department of Psychiatry, and I do a number of things, some of which is clinical activities at various sites around the state. And I'm really pleased to be talking with you today about post-traumatic stress disorder. I can shift back over to the thing. So we're going to go over a number of things, and so by the end of our time today, we'll have discussed the clinical presentation of PTSD, including some of the changes that have occurred with DSM-5, since I think that many folks are still in transition between the old version of DSM and the current version. We're going to talk a little bit about the prevalence of post-traumatic stress disorder in the general population, but also think about how it impacts some special populations. We're going to talk about factors that alter the risk of developing PTSD after traumatic events. I'm not going to spend a lot of time on the neurobiology, but I'm going to summarize it in part because it bears on our ideas about treatment approaches. And we're going to talk broadly about treatment strategies, and probably we'll spend just a little bit more time on a particular treatment modality, eye movement desensitization and reprocessing, or EMDR. So what is PTSD? When somebody experiences a significant event, one that typically poses a threat to life or safety, these include an assault, a serious accident, war, natural or man-made disaster. A series of reactions occurs that initially could be considered normative, and if anybody in the room has been even in a minor fender bender car accident, you know that there are things that are different about how you view driving for at least a little bit of time after that. So the responses can be considered normative when they're transient, but in individuals with PTSD, they become fixed and they stay around for a long time, and they really intrude on normal functioning. In the current system of the Diagnostic and Statistical Manual, DSM-5, these responses have been organized into 4 clusters. The first is intrusion, which includes symptoms like nightmares, flashbacks, which is where you relive an incident of an old event, intrusive or recurrent memories, which are different in character than flashbacks, but are certainly pretty intrusive and hard to avoid. A second cluster is the avoidance of reminders. This can manifest in a variety of behaviors. Some people might need to change TV channels if a show or a topic on the news came up with that was a trigger for them. They may not be able to use a car, or they may stay away from a location where a traumatic event happened, but it might also include amnesia for all or part of the event. A third cluster, which is actually newer, this negative emotions and or mood and cognitions used to be interspersed with the other categories, includes irritability, a negative outlook, and this is where you can think about some of the ideas about having a foreshortened future, or the idea that your life has been somehow irrevocably changed after a traumatic event. And then finally, the body manifestations, which includes increased arousal and reactivity. So this would include watchfulness, increased startle reaction, people who tend to sort of walk around with their palms sweaty, and the like. The diagnostic criteria are available in the DSM and several other resources, so I haven't listed them completely here. But they also include some of the stressors that precipitate the event, duration criteria, and the typical DSM criteria that ask you to think about a differential diagnosis and make sure that this is the best explanation. The other thing that's new in the DSM-5 is that they've established criteria for children under 6, and this is for the first time. Before this, individuals working with little kids were having to adapt kind of on their own the general diagnostic criteria for PTSD. So I'm going to go over a few of the things that are different for this 6 and under category. So showing immediate distress, which used to be one of the diagnostic criteria, has been eliminated because there may be no way for very young children to really do this. It's not part of their developmental capacity in many circumstances. The second change is that the language for intrusion has been altered to account for young child development. For example, instead of being distressed by intrusive memories, kids might show more general and maybe harder to interpret responses, such as a general overall kind of excitement. One of the other changes is that the requirement for avoidance has been lowered to just a single symptom because, again, it is less common for kids to be able to or go through extreme lengths to avoid situations that are concerning. And finally, under the arousal reactivity criterion, extreme temper tantrums was added for these little kids. The last thing that I'll say on the new criteria in DSM-5 is that they have established additional specifications that include delayed onset of symptoms and a dissociative subtype. So I thought it would be useful to summarize just a few clinical examples. So the first that I'm going to just read to you, and some of the key symptoms are actually underlined in the presentation. So a 5-year-old boy who was living in a household with his parents. Dad was involved in methamphetamine production, and this child also had some prior exposure to violence related to living in a house where there was a lot of drug-related activities going on. He was in and witnessed a house fire, and one of the particular characteristics of this event is that his father actually caught fire, and he had to see his father running out of the house and being physically on fire. In the aftermath of this event, this youngster displayed very poor sleep. He seemed more irritable than his baseline and defiant more so than his baseline. And the other thing that was true of him is that themes in play changed, and so he was focused a lot on heroes, superheroes, good versus evil, power, danger, and safety, whereas previously his play activities had been a lot broader. So there's another example of a slightly older youngster, a 16-year-old girl who, after a period of time, disclosed being repeatedly molested by a youth group leader in the town where she lived. She also reported nightmares and experienced panic when seeing men in the community who looked like her assailant. She refused to go to the area of town where the molestation had occurred, where the community center was, and she would not watch TV that had anything to do about rape. So news reports or any kind of fictional stories on TV, it didn't matter. She would turn off the TV or leave the room. She also reported feeling distant from her mom, from whom she'd really previously had whom she'd really had a good relationship, and who was a really good source of support to her previously. And she also experienced insomnia, general irritability, and was easily startled. So going to move on into the full adult years, and this example actually came from a PBS program about the effects of war. In this instance, a 26-year-old Iraq vet who reported being in multiple firefights returned to the States after an injury, and he reported nightmares, recurrent, very distressing recollections of things that had happened to him. He felt completely shut down, numb, and distant from his family, including his new baby. And he also experienced anger, an underlying just general irritability, and a sense that his sort of future had been ruined, or a sense of foreshortened future. It should be noted that it's not required that an individual actually experience trauma firsthand. It is possible to hear of an event and still develop post-traumatic stress disorder. So this has some implications for exposure to media, especially after a community-wide event, and for parents of younger children. It is probably going to be really important to monitor the kinds of media exposure young children have when there's a community event, because even though they may not have witnessed the event firsthand, they can be traumatized by hearing about it repeatedly in the media thereafter. These vignettes each illustrate how distressing PTSD can be. And one of the ironies to me is how the symptoms, especially the avoidance and the emotional numbing, can actually get in the way of people seeking support from friends and loved ones or seeking care. So we're going to shift over to a little bit of epidemiology. So when considering the prevalence of PTSD, it's useful to think about the general population, where the overall prevalence is about 8%. It probably varies some depending on the study. But then consider the relationship of other factors like gender and race or ethnicity. At present, our best estimates would indicate that women overall are at higher risk of developing PTSD than men. This seems to be a result of overall risk of exposure to traumatic events. There are also differences in the kinds of exposure by gender. Men are more likely to experience violence in the context of work activities. For example, individuals who work as police, firefighters, and soldiers. And women are more likely to experience interpersonal violence, such as domestic violence and sexual assault. Ethnicity differences also exist in the prevalence of PTSD, and these seem mostly to be connected to the overall risk of exposure to adverse or traumatic experiences. Finally, it's also really critical and timely to be aware of special populations. For example, in Iraqi war veterans, the prevalence of PTSD has ranged from 4 to 17%. Children who are involved in dependency care, such as child welfare, PTSD is present in as much as 15% of those youngsters. And there is a substantial proportion of individuals in our prison and juvenile justice systems who experience post-traumatic stress disorder, about 11% in the juvenile justice population and 4 to 10% in the adult population. I'm also going to say here that it is possible, certainly, and I think that the data are less clear on the prevalence of what we would call subsyndromal post-traumatic stress disorder, which means individuals who have some symptoms of PTSD but probably would not be able to be eligible for the diagnosis in its fullest sense. So what affects the risk of post-traumatic stress disorder? Because clearly not all who experience traumatic events develop PTSD. So a number of factors increase the risk of developing post-traumatic stress disorder after a traumatic exposure. One of these is a family or genetic vulnerability to mental health disorders in general. So a family history of depression or anxiety increases the risk of developing PTSD after a trauma. Individuals who experience trauma in their early years and then experience subsequent traumas are at increased risk for developing post-traumatic stress disorder. And I'm going to come back to a little example about this in just a second. The type of exposure event also seems to play a role in the risk. So the level of violence, the increased level of violence increases the risk. Repeated or recurrent events increases the risk, as well as a certain degree of unpredictability to events. All of those increase the risk. And then finally, there are a number of characteristics that individuals have that foster resiliency and therefore reduce the risk of developing PTSD. So some of these are a strong sense of self, the capacity to access support, either both from the person's individual capacity to seek out support and the availability of support, the presence of the sense of humor and some capacity in personality style or temperament for adaptability. So I have a couple of specific clinical examples, but there was a young man I met some time ago who had a really quite intensive traumatic past where for a period of time he was actually living in the household with a step parent who had been in the war situation in the Middle East, and for a block of time the whole family essentially lived under siege. This kid knew more about weapons and different kinds of guns that I will never know in my life. The family was essentially in the house all the time. The children were allowed to go to school and to come home, and with no extracurricular activities. And they couldn't even really walk the dog. They would put the dog on the leash, open the door wide enough for the dog to get out to the end of the leash, and then would pull the dog back in when they were done. One of the unfortunate characteristics of this youngster, because of his knowledge of the wars and military, is that he really had a desire to go into the military. And I raise this because this would be the kind of youngster, as a soldier in any of the branches of the military, who would be at very high risk of developing post-traumatic stress disorder under the stressors of war. So this is really the one single slide on neurobiology, because the neurobiological basis of PTSD and theories about this are just so numerous that it would be beyond the scope of this talk. I'm summarizing them here because they are connected to our current ideas about treatment modalities. And the other thing that is, new modalities are tested. It will depend on continuing to develop our best understanding of the impact of trauma exposure on the brain and therefore on emotions and behavior. So we do know that there are a broad range of brain changes after traumatic exposures. Some of these are in the brain's neurochemistry, so the catecholamine systems that modulate the levels of epinephrine, norepinephrine, and dopamine. The stress system that releases cortisol in response to stress in the normal individual, and the other chemicals that are part of the regulation of that system, the hypothalamic pituitary adrenal axis. In individuals with traumatic exposures can become kind of chronically altered, so that cortisol is elevated, and sometimes some of the short-term cortisol response to an acute stressor is attenuated a little bit. It turns out that this is kind of complicated. Over the many years that people have been measuring the impact on the HPA axis, there's a certain amount of variability depending on how you measure different parts of the system. In terms of neuroanatomy, there are a number of brain structures that are impacted after traumatic exposures, and this too depends a little bit on whether you measure young children or you measure adults. But some of the key brain structures that are impacted is the amygdala, which is deep in the brain and is part of the fear response. And other primal emotional kind of responses. Another part of the brain that is impacted is the hippocampus, and we know that the hippocampus is involved in the development and maintenance of memory and memory retrieval. But there are also other areas of the brain that are affected, including in some studies parts of the corpus callosum, which connect right and left sides of the brain, and the different parts of the prefrontal cortex. So all of these changes, as they occur, ultimately affect the emotional reaction that occurs with PTSD, and also memory and learning. And these are also some things that our treatment modalities try to pay attention to. So I'm going to shift to interventions, and I'm going to start with a couple of overall slides and then get into just a little bit more detail. So there is evidence for a variety of treatment or interventions for post-traumatic stress disorder. I should say that the data are more extensive in adult populations than in child populations. And one example of interventions are medications or pharmacologic interventions. And so we're going to be talking about the selective serotonin reuptake inhibitors, the serotonin norepinephrine reuptake inhibitors, other antidepressants, antipsychotic medications, central adrenergic agents, and anticonvulsants, because all of these have had some studies attempting to help people with PTSD symptoms. After talking in a little bit more depth about the medications in a couple seconds, we're going to talk about some of the psychotherapeutic modalities for post-traumatic stress disorder. Again, these have variable strengths of evidence. The three listed here, cognitive behavioral therapy, and I'm going to talk a little bit about a variant called trauma-focused cognitive behavioral therapy, exposure therapy, including prolonged exposure, and eye movement desensitization and reprocessing, or EMDR, have strong to moderate evidence to support them. So I'm going to go back to the medication interventions and say of the SSRIs, only sertraline or paroxetine are FDA approved for adults with post-traumatic stress disorder. Individual practitioners may use the other SSRIs, but they are right now considered off-label. And this is in adult populations. There have been even fewer trials in pediatric populations, a couple of which compared treatment as usual in the community to trauma-focused cognitive behavioral therapy, and then third to an arm where trauma-focused cognitive behavioral therapy was provided in combination with medications, and that medication addition did not seem to significantly benefit people more than trauma-focused CBT. And at this point, SSRIs are, no SSRIs are approved, actually no medication is approved by the FDA for treatment in youngsters. They can be considered, there are certain circumstances where either A, symptom clusters are pretty severe and there's some concern about the emotional distress that a youngster is in, when a practitioner might consider using medication such as an SSRI, and in addition to other kinds of modalities, at least for a period of time. And in adult patients, there is some evidence that the SSRI use in combat-related PTSD, that SSRIs are less likely to be effective. There's some other tests, some other research studies that have been done on other antidepressants, including venlafaxine. There have been at least a couple of randomized control trials in adults that have shown some reduction in PTSD symptom counts in those individuals. And then some other medications that also adjust serotonin levels, nifazodone, which is hardly used anymore, in one study showed improved PTSD symptoms, and mirtazapine had one study showing improvement in some PTSD measures. I think some of the newest antidepressants have probably not yet been studied for this particular population. Some of the newest antidepressants have indications more for mood disorders. A second class of medication that is sometimes used for, sorry, I got behind on the slides. This is what happens when I talk and don't think. Is the second generation antipsychotics. So olanzapine has a small randomized control trial showing improvement in post-traumatic stress, and risperidone had one open study pilot and one randomized control trial, both of them showing improvement in post-traumatic stress symptoms. There have been some other studies that have been done on some of the other second-generation antipsychotics, and with somewhat smaller effect sizes. The mechanism for the second generation antipsychotics is not terribly clear. Some of the biological data would point to the relationship between PTSD and serotonergic and adrenergic systems, but it's possible that modulating dopaminergic activity could have an overall combination regulatory improvement. The other thing is that the dopamine blocking agents in the second generation antipsychotics also don't only act on dopamine, but act on a variety of neurotransmitters. And so it is certainly possible that this explains the underlying mechanism for their activity and the improvement in symptoms. I'm going to talk just briefly about anticonvulsant mood stabilizing medications. Divalproex, topiramate, and tiagapine have had some studies, but there have been mixed results. These medications are not currently recommended for post-traumatic stress disorders. It is possible that they might be useful in individuals who have coexisting other disorders that might be better treated by the anticonvulsant mood stabilizing class. There have been a few studies looking at centrally acting adrenergic agents, and it makes sense, given what we know about post-traumatic stress disorder, that these agents might actually be helpful in these circumstances, but the studies are relatively few. So prazosin has a small open placebo-controlled, some small placebo-controlled trials, and has shown a reduction in nightmares, overall improvement in sleep, and some improvement in general PTSD symptoms. So this is something that is relatively commonly used at this juncture. Again, it remains off-label. And there have been a few trials of other agents such as guanfacine and clonidine, again with mixed success, and both of these remain off-label for post-traumatic stress disorder. Sort of an added note, you might hear or see examples of individuals, especially with kids, even under circumstances where they don't have clear-cut post-traumatic stress disorder, but have some symptoms of excessive arousal and emotional regulation difficulties, that some people might attempt trials of guanfacine or clonidine to help with this, but we don't really have systematic study at this point to recommend it. Beta blockade medications had one open trial where they seemed effective, but the data hasn't really been replicated in other kinds of trials. So we're going to shift over to psychotherapeutic interventions, which really are probably the mainstay of, or should be the mainstay of treatment. So we're going to talk a little bit about cognitive behavioral therapy, exposure, and EMDR. There's some degree of overlap in the practice of these modalities, and then some things that distinguish them. And across the board, each of these modalities is grounded to some degree in learning theory, so how we intake new information, including information that arise out of traumatic exposures and how it changes our views of the way the world works, and also ideas about how we store and retrieve memories. So I'm going to talk about cognitive behavioral therapy first. It is a time-limited psychotherapy technique. It is usually, according to its manual, it is run in weekly sessions. It can be done on an individual basis or in a group setting, and is usually done on an outpatient basis, although it has been incorporated into inpatient psychiatric treatment and residential settings. During treatment, patients are encouraged to put their ideas about trauma into words. Consider whether any of the ideas that they have about the impact to their future life and experience are distorted or unrealistic. For example, it's common for individuals exposed to trauma to assume that they are at fault, and if so, learning to challenge this distorted thinking is certainly important to improved emotional well-being, as is the ability to do an appropriate appraisal of threat. Cognitive behavioral therapy also typically includes behavioral techniques, especially those intended to improve capacity to relax the body physically, which again also improves health and well-being. I'm going to give a second example of an individual that I was once treating for depression and anxiety. This was a relatively young adult, and this person didn't have formal PTSD, but they had experienced harsh parenting, probably bordering on maltreatment when they were young. And one incident that I have a hard time forgetting about this individual is that at one point they were in for a routine appointment, and they looked out the window, and it was a cloudy day. I mean, this is Michigan. It was a cloudy day with light rain, but there wasn't really any threat of storms. And this person said in a pretty emphatic tone of voice, "It's always storming when I come here." And so for us, this was a window to talk about how perceptions can be altered, and including an increased sense of danger even when it's not warranted, and how that might affect day-to-day functioning. So the next treatment modality is exposure. This is also typically time limited. It can be very brief time limited, 1 to 2 sessions, or prolonged exposure that occurs over 10 sessions or so. There's actually pretty strong evidence for prolonged exposure modalities, and it focuses on re-exposure to the traumatic event, which can be either in vivo in real life, which is direct exposure to some environment in which events took place, or by the use of memory or imagination, and memories of the event can be explored either in written and verbal form. And the idea is for an individual to expose themselves to that traumatic event again, experience some of the emotional and physical distress that comes with that, and then through support to be able to calm themselves back down. And get better and better at doing that, so eventually they can recall the events without reliving them, which I just said right here. I looked at some more recent literature on exposure versus other modalities, and there's some indication that exposure is actually underused given its evidence base. Not entirely clear of the reasons why. It's possible that practitioners don't necessarily feel comfortable inducing the anxiety and emotional distress that comes with the recall of these events in office-based settings. The last modality we're going to touch on briefly is EMDR. This is also a time-limited intervention. Sometimes it's actually been done as a single session, but it can entail multiple sessions. At each session, a patient is asked to recall a specific traumatic event or some aspect of the event, and once they have entered that recall mode, the therapist assists the patient with participating in some kind of physical activity or stimulation. It can be horizontal eye movements, which can be done by having lights up and asking the patient to look quickly back and forth between a set of lights. It can sometimes be vertical eye movements, bilateral tapping of the fingers or hands, or even the therapist tapping on the individual's shoulder, for example. It should be noted that although EMDR is considered a practice that is a reasonable one, it's not been without controversy. Part of the issue has been with the quality of the studies, including the variations in the methodology. For example, some of the clinical trials were conducted with participants who did not have a confirmed diagnosis of post-traumatic stress disorder, but instead had been exposed to disturbing events, and their degree of potential for trauma varied. Secondly, the measures of improvement have been different across studies, including subjective distress, specific PTSD symptoms, or just global improvement scales. Early in the institution of EMDR, some of the studies were not published in peer-reviewed journals, which also made the results a little bit more suspect to individuals used to evaluating psychiatric research that was done and published in a peer-reviewed setting. There's also been methodology in the performance of EMDR, and it's not clear about which part of the practices are required for effectiveness. For example, some meta-analytic studies comparing EMDR with and without eye movements, which is kind of sort of a contradiction in terms, but it can be done, didn't show that the results arising from the two conditions varied. It's also not clear whether which kind of physical activity, eye movement versus tapping, versus having vibrator units that go on and off in hands versus other memory tasks, are equally effective. And it's also then important to think about how this might connect with the theory of the mechanisms underlying EMDR. So the other thing is that there are meta-analyses looking at EMDR and showing that it isn't necessarily superior, but maybe just equivalent to other treatments. And finally, not just for EMDR, but across the board, more work is needed to determine whether EMDR will be any more specifically suited to certain kinds of trauma exposure. For example, might it be more effective with individuals who have undergone sexual maltreatment versus individuals who have been exposed to trauma through combat? So we're going to shift to the last topic in the last few minutes. So what are some of the options to address trauma, depending on where it occurs in different clinical settings? It's not listed on this slide, but really the first step is awareness on the part of practitioners about the prevalence of trauma exposures and the range of potential impact. So it might be worthwhile for individual practices or organizations to consider screening on a regular basis for trauma exposure and impact. There are a number of options for this step. However, before implementing any screening protocol, it will be important to plan for the next steps, like what happens when a patient screens positive for trauma and/or for symptoms of post-traumatic stress disorder. So there are a number of ways to think about sort of finding out what the resources are either in the area or what resources a practice might have to develop. One of these is to be talking with the commercial insurers or Medicaid health plans your office participates with to see how they develop their trauma-informed services are. For example, do they offer to participating providers or do they require training for providers on evidence-based trauma treatment strategies? Do they even know if any of their impaneled providers have training in evidence-based trauma or PTSD interventions, for example, CBT, or trauma-focused cognitive behavioral therapy, or any other treatment modalities such as short-term or prolonged exposure and EMDR. I will say that the Medical Services Administration at the state within the Department of Health and Human Services does have a trauma policy. Right now, this language is for children and adolescents up to 21, and it is folded into the early and periodic screening, diagnosis, and treatment guidelines. And so you can look at Bulletin 16-46 for more information on MDHHS policy. In the community mental health system, providers are developing the capacity statewide to screen, assess, and intervene when individuals are impacted by trauma exposure. The Behavioral Health and Developmental Disability Administration has policy on trauma that guides CMH providers generally, and the Division of Mental Health Services to Children and Families, which is now in the Children's Services Agency, has a trauma initiative that's been in place since probably 2008. And this has included recommending that community mental health service providers incorporate screening with using an evidence-based tool into their practice, and then build in strategies for assessing children whose screen is positive. And they have also been working to train providers in the community mental health service system in trauma-focused cognitive behavioral therapy, which is a specific variation of cognitive behavioral therapy focused on psychoeducation about trauma and its impact, preparing an individual to manage the emotional distress that comes with some aspects of recalling trauma, and then build a trauma narrative so that they can begin to restructure some of the possibly distorted ideas that they have, as well as engage in some practical planning to improve safety in the future. So they have been training in trauma-focused cognitive behavioral therapy, and a companion part of the training is some trauma-specific training for resource parents. And so you can find out more about that through contacting your local community mental health systems. The other thing that I'll just mention to keep in mind is that the state is also just recently developing an initiative related to fetal alcohol spectrum disorder that will also include some tools for assessment and engaging in some evidence-based interventions. And I mention it in this context in part because there is some overlap between circumstances that lead to fetal alcohol exposure and the potential for children also having other traumatic exposures. So there's a number of places to think about finding resources to look into this topic further. One is that there is a relatively new initiative called the Statewide Initiative to Address Adverse Childhood Experiences, and this is across the lifespan. Anybody who hasn't yet heard about the Adverse Childhood Experiences Study, it was in a couple of decades ago. It was started out of the Kaiser Permanente system, and internists in that system began asking patients about their childhood exposures to a number of adverse events, and found a direct correlation between adverse event exposure and a number of health-related consequences into the adult years, health and mental health, substance use disorders, etc. And so the state is working on developing the means to make sure that people are aware of this, and then maybe how to mitigate some of these difficulties that arise. And so there's a website, http://mahp.org/ACE-grant. Secondly, MDHHS, Department of Health and Human Services, is in the process of, and I think it should be up and running by now, substantial revisions to their trauma and toxic stress website. That's www.michigan.gov. The M doesn't have to be capitalized, /trauma toxic stress. And so that will have a number of information. It has good links to other sources, so it's a great place to find out more about trauma and toxic stress. And I'm going to give you a couple of other resources. One is the National Child Traumatic Stress Network, www.nctsn.org. The revised version of this PowerPoint that'll be uploaded after this webinar completes will have these last two references. This organization is a clearinghouse for evaluating the evidence base for different kinds of screening, assessment, and treatment. And it has a wealth of information for medical providers and mental health providers, for caregivers such as parents and foster parents, and school personnel to assist with developing a coordinated system of care. And finally, the California Evidence-Based Clearinghouse, which is www.cebc4cw.org, and again, that will be up on the revised PowerPoint. This is a clearinghouse that evaluates the quality of different kinds of tools, including screening, assessment, and intervention approaches, but it also offers some guidance to organizations that they can use to complete a self-evaluation about their readiness to engage in trauma-informed services, and then some guidance for completing strategic planning activities. So finally, just to conclude, so certainly trauma exposure has broad-ranging mental health consequences, not only post-traumatic stress disorder, but that is one significant one. There certainly evidence that the impact on the brain, emotions, behavior, memory, thinking, and the physical manifestations of trauma are important and continue to inform the development of treatment modalities. The evidence base for our pharmacological treatment is still limited and in evolution, as actually is the evidence base for psychotherapeutic psychotherapeutic strategies, although we do have a stronger evidence base for many of the psychotherapeutic and behavioral strategies. And at this point, more is needed to be able to think about whether there are specific treatment modalities that are more tailored to different kinds of trauma exposure and related PTSD. So that is the last slide in the presentation, and so we have some time to open it up for questions.
So we will go ahead and do a question and answer portion. What I would like for everyone to do is we're going to start with the audio sites that are on the line, and we're going to start with the Lower Peninsula sites. Please unmute yourself and state your first name and the site that you are at so that we are aware where you're located.
Question. Where's she going by?
Karen Myers, Northern Healthcare Management.
Go ahead.
I don't think you have to identify yourself unless you have a specific question.
Yes, yes. I'm sorry to
not
confuse
asking
you.
for an attendance roll call, but as a preliminary to those who might have a question.
Are there any questions in the UP audio lines?
Kalkaska Memorial Health Center, we're in the Lower Peninsula. I do have a
Kalkaska.
question. Hi. I find that some of the women have coming in, we're probably number 2 in the Northern Peninsula, or in the northern part here, that have children that have been molested by their parents. And I'm trying to find out if there is some type of study that's been done for these children, once they grow up and become adults, have hypertension, have a history of hypertension because of the anxiety.
Hopefully the delay is now over. I keep forgetting about the delay. Yeah, I mean, I do think that certainly hypertension was one of the chronic health conditions that was covered under the ACEs study. And yes, there is an association, and it's probably related to a number of different factors that underlie the neurobiological consequences of maltreatment, including the hypothalamic pituitary adrenal axis, because cortisol as a stress hormone has a number of impacts on the body, and also the catecholamine systems, which are absolutely normatively connected to control of cardiovascular activity. So yes, thinking about that in advance, thinking about the other kinds of risk factors that individual might have because of, say, family and genetics, and also thinking about additional risk factors such as diet and exercise, and exposure to drug and alcohol use. I mean, all of those are really important to consider for the long-term health of individuals. One of the best things I think about the ACEs study is that is that it really transformed our public discourse about the impact of trauma, taking it out of kind of a social welfare moral question and turning it into a set of questions and discussion about public policy and public health. So yeah, I don't know. I mean, what I would do if I were you is I didn't give this thing, this resource, but I will now. So there is actually an ACEs website. So if you just Google Adverse Childhood Experiences Study or ACEs, that is one place. And another place that has a lot of information about how to use information from the ACEs study in clinical practice is an organization called the Academy on Violence and Abuse. Its website is ava.org. And they have also a wealth of information about translating some of what we know from the ACEs study into practice, in clinical practice.
Thank you.
You bet.
Are there any other sites that are on via audio that have any questions?
Hello? Can you hear us?
Yes, we can.
Oh, from Kingsley, K-Town. Would you think that doing timelines on kids who've had a similar experience with a stepfather, like the example you shared about the military and the extreme parenting, do you think that doing timelines with cognitive behavioral therapy is helpful in processing those memories?
It makes reasonable sense to me to sort of think about that. I'm trying to think whether or not, right off the top of my head, whether or not in discussions about implementation of, say, trauma-focused CBT, how timelines as a therapeutic tool would fit into that modality. But yes, certainly when, especially when you're considering the possibility of multiple exposures over time, getting a sense of that as part of, say, developing a trauma narrative would certainly make intuitive sense to me.
Good, because I have been working with one client that I'm working with, because he tends to dissociate from the memories at times, and he forgets a lot of detail. So he's kind of gets stuck in where he's at. So
certainly trying to also find ways to help individuals kind of come back into sort of day-to-day awareness under circumstances of experiencing a trauma trigger is certainly a reasonable thing to try to work on.
Okay, thank you.
Hi, this is Kathy from Traverse City. Can you touch a little bit more on how a child develops resilience? I know you said it was a strong sense of self, but how do they develop that when they're surrounded by so much dysfunction?
Yeah, well, certainly, I think there's probably a couple of possibilities. One is that even in the setting of dysfunction, it is possible that there are some aspects of the relationship with any parent or caregiver or even extended family member that might be possible, that might be a source of support. And so trying to think with that youngster and with people who know that youngster about who those sources of supports are and what some of the lessons that they might have learned or positive memories that they may have would be an important thing to consider. It would probably also be, what's the word I'm looking for? Most kids, once they hit a certain age, are involved in public activities such as school or possibly other kinds of extracurricular activities, even if they are experiencing maltreatment in their homes. And so looking very broadly at that kid's total environment and finding as many sources of more average adult-child relationships and peer-to-peer relationships, thinking with that youngster about the things that they are kind of accidentally gifted with, for kids who may be natively good at sports, encouraging and sustaining those kinds of activities that continue to develop a sense of accomplishment and well-being. All of those are kind of possibilities to build resilience. There's a whole literature on resilience, actually, that was also probably would have been too much detail for the time that we have today.
Are there any other questions via audio? Okay. As far as the video sites, are there any comments or questions for Dr. Scheid? Okay, well, thank you everyone for joining us today. And again, you have until August 9th to complete all your forms to receive continuing education. And I'm sure Victoria, once she gets back to the office, if you have any other additional questions, please contact her. Have a nice day, everyone.
Thank you.
Yes, not smartphone period. I didn't know we changed our name. But they're not asking this day. Oh, I forgot I taped it down.